Okay. You started?
Yeah.
Hi ladies, I'm Belita, I'm a resident, and and you are?
Nadia, I'm from respiratory.
Okay.
Hi, I'm Christina. I'm from respiratory as well.
Oh, hi. Well, I have a problem, I need your help.
Okay.
I have a patient, she's 5'8", she's 28 years old, she has a very long history of poorly controlled asthma. Her vital signs are 100.4, her heart rate's 108, her respirations is 30. Her blood pressure is normal, 120 over 80,
Okay.
and her SpO2 is 82%, and she's on a 40% air entrainment mask. What do you suggest?
Okay, this is the patient in the 308, right? I just draw her ABG, and I have here, let's see, the pH is 738, PCO2 is 44, PO2 is 55, BICAP is 32. Also, you said the saturation is 82. Although the patient ABG is within the range, the normal range, but she is in rapid shallow breathing, and the workup readings evidence of current respiratory rate of 30.
Okay.
So she is in severe hypoxemia because of the 40% of FiO2. She's current
Okay.
independent mask.
Okay. And so I just had a chance to do the alveolar air equation, and her PO2 should be at 260 with the air entrainment mask of 40%, but you know, again, the PO2 is 55%. And I also had a chance to auscultate the patient, and the patient had a lot of audible wheeze.
Okay, well, chief resident is ready for a plan, but there's one catch. The patient does not want to be intubated.
Okay.
What do you think you can do?
I can recommend that maintain the patient for 1 hour in continuous small nebulizer with albuterol and Atrovent.
Okay, and along with that, I think we can also put the patient on a bi-level ventilation and start the setting with maybe a IPAP of 10, EPAP of 5, and the respiratory rate of 14. And then since the patient isn't doing so well on a FiO2 of 40 right now, we can increase the FiO2 to 50%.
Okay, well, what would bi-level ventilation do for the patient?
Well, bi-level ventilation with the IPAP, it will help to augment the patient's tidal volume, and the EPAP will help with oxygenation and also splint open the airway for the patient. And then also we can, if the setting, right now the setting we're thinking of 10 over 5, and if that doesn't work, we can always titrate it, increase the setting for the patient to help whatever works for the patient.
Yeah, also I recommend draw another ABG like 30 to 40 minutes after the treatment to see how the patient is doing.
Okay, that sounds good, good plan, but what if the patient is still in distress with increased work of breathing and increased respiratory rate? What would you suggest?
And if that's the case, then it will be evident the patient after drawing the ABG, and it does show that the increase of PCO2 and also the pH is going down, it would evidence by that the patient is in ventilatory failure, and I would then recommend the patient to be intubated because, you know, she cannot protect her airway, and I understand the patient does not want to be intubated, but we need to do what we need to do to protect the patient's airway. And so maybe we can start off what we have recommended and planned. How's that?
Okay, yeah, I think that's good. I'll tell the chief resident, and we'll go with your first plan and see how that works out.
Okay, sounds good, and we'll
Okay.
come back with some updates, and then we can get to work.
Okay, thanks,
All right,
ladies.
thank you.
Okay, bye-bye.